covering three important topics or three important best practices which are associated with antibiotics. First is your acute meningitis. So most of you, what is the empirical drug of choice for acute bacterial meningitis? So I'm sure most of your places will be giving ceftriaxone plus vancomycin. Is it correct? Second question I'll be addressing is the use of newer BLB alike, that is your ceftazidime-avibactam. Then third important topic I'll be addressing today is your surgical antimicrobial prophylaxis. Welcome back to my channel. So today I bring the third in series, Busting the Myths. So for those of you who have not seen the other two in the series, Busting the Myths 1 and 2, I will attach it somewhere here. So yeah, let's get started. So acute meningitis. So this is a very common scenario, acute bacterial meningitis. So what is the empirical treatment of suspected acute bacterial meningitis? Is it ceftriaxone plus vancomycin, which you're using regularly? Is it the correct choice? Okay, so let's discuss this. So whenever you're suspecting a patient to have acute bacterial meningitis, apart from the CSF sample, it is necessary that you collect the blood sample as well for the cultures. So this is an algorithm which is given by the IDSA 2014 guidelines for treatment of 2004 guidelines for treatment of bacterial meningitis. Whenever a bacterial meningitis is suspected, and you will have to take the necessary history, whether if the patient is having immunocompromise or history of CNS disease, or if he's having new onset seizures or papilledema. So basically, the new onset seizure, papilledema, these are little contraindication for performing LP. Then whether the patient is in altered consciousness, so basically to differentiate whether it's actually meningitis or acute meningoencephalitis, or if the patient is having any focal neurological deficit, or if these factors are there and there is no contraindication for LP, you can perform the LP. Once LP is performed, you have to send even the blood culture stat, that is immediately. And suppose if the blood cultures, then you will be starting the patient on dexamethasone with empirical antimicrobial therapy. And next, based on the CSF findings and the CT scan, you will be proceeding further. So irrespective of whether you can perform the lumbar puncture or not, you'll have to collect the blood cultures as well as CSF sample after you do the lumbar puncture, which you have to send it for all the necessary investigations. So CSF will be sending for what the routine parameters, the biochemistry and the cell count and your gram stain and culture sensitivity. And if you are suspecting and based on the cell count, again you will be thinking whether it could be bacterial or viral or tubercular, and then based on that, again further investigations you'll be proceeding to. So again, the CSF gram stain has a variable sensitivity depending upon the type of organism. For Streptococcus pneumoniae, the CSF gram stain sensitivity can be as high as 85 to 90%. And if the CSF gram stain has a very great specificity, but sensitivity is quite low. So even if the patient is having negative CSF gram stain, you will be continuing the empirical therapy with the dexamethasone. If it is positive, depending upon the type of whether it's gram positive or gram negative, you will be considering the targeted antimicrobial therapy. So in acute bacterial meningitis, what are the clues towards your acute bacterial meningitis? The CSF may appear cloudy depending on the presence of significant concentration of WBC or bacteria or protein. In cases of untreated bacterial meningitis, your WBC count will be quite high, 1,000 to 5,000 cells. And it will be predominantly neutrophilic predominance, typically between 80 to 95% neutrophil predominance. CSF glucose concentration usually will be less than 40, but again, this has a variability, and it is always necessary that along with the CSF glucose, you look at the blood glucose, corresponding blood glucose as well. And the ratio of CSF to serum glucose is generally less than 0.4, less than or equal to 0.4 in cases of bacterial meningitis, and the CSF protein is elevated, usually in the range of hundreds. So when the patient is having this picture, you will be suspecting acute bacterial meningitis. As I mentioned, you will be giving empiric antimicrobial. So what is the choice of your empirical antimicrobial? Again, depends upon the age of the patient. So usually the infants, in the neonates less than 1 month, the age is very important because your typical microorganisms which cause meningitis differ in less than 1. Streptococcus agalactiae, E. coli, Listeria monocytogenes, Klebsiella, basically those of the maternal vaginal flora, or these flora will be more important in causing. So that is why in these cases you can consider ampicillin with cefotaxime or ampicillin plus aminoglycoside. In age group between 1 month to 23 months, Streptococcus pneumoniae, Neisseria meningitidis, Streptococcus agalactiae, Haemophilus influenza, E. coli, where this is based on the IDSA, where they give vancomycin plus third generation cephalosporin. And in 2 to 50 years age group, Neisseria meningitidis is Streptococcus pneumoniae, that is a more common organisms. So that's why the empirical choice as given by IDSA is Vanco plus your third generation cephalosporin, like your ceftriaxone or cefotaxime can be used. And basically your third generation cephalosporin needs to only have the adequate CNS penetration. That is why you will be using these agents. More than 50 years, again, your GNBs and Listeria will become more common. So that's why we'll be adding the ampicillin cover. And then if the patient is having any history of head trauma, other different organisms, other group of organisms like group B, hemolytic streptococci, Staph aureus, gram-negative bacilli, including Pseudomonas also will become important. So depending upon that, you will be choosing the empiric therapy. Post neurosurgery, just like any other, so post neurosurgery, any EVD, your aerobic gram-negative bacilli, which are mostly hospital acquired, again will become more common. So that is why you will be choosing vancomycin plus cefepime or vancomycin plus ceftazidime, etc. CSF shunts, again your cons, Staph aureus, and other GNBs which are hospital acquired. So that is why you'll be choosing the vancomycin plus cefepime or vanco plus ceftazidime or vanco plus meropenem. So coming to the situation in India, so is ceftriaxone plus vancomycin a rational combination in India? So what is the rationale? Why are they suggesting empiric ceftriaxone and vancomycin? Why are they suggesting? It's very important to understand. So as I mentioned, the different age groups, the most common normal patient presenting with meningitis is not your Staphylococcus aureus, and your rationale of adding vancomycin here is not to cover your Staphylococcus aureus. So basically, the rationale is to cover Streptococcus pneumoniae. In the Western world, there is higher incidence of penicillin non-susceptible Streptococcus pneumoniae. So the for Streptococcus pneumoniae, your penicillin or the beta-lactam agent is the drug of choice. So there is in higher incidence of penicillin non-susceptible Streptococcus pneumoniae in the Western world. That is why they prefer the combination of ceftriaxone and vancomycin to cover these isolates. But when you look at the same thing in India, the NSSP, that is non-susceptible Streptococcus pneumoniae, is very less. It can be ranging between 0 to 1%. Again, there is no nationwide study which is there, but various studies, individual like retrospective studies, and these suggest the incidence, the prevalence is very low, 0 to 1%. Hence, in India, empiric acute bacterial meningitis treatment can be only injection ceftriaxone 2 gram IV over 3 hours. BD. So this is not the usual dose of 1 gram, it is 2 gram, and you will have to give over 3 hours, at least 2 to 3 hours, because as I mentioned before in my webinars, any beta-lactam agent you have to give it has time dependent action, so you have to give a prolonged infusion. So this is the national treatment guidelines for antimicrobial use, that is the national guidelines published in 2019. Again, here you can see the drug of choice empiric therapy is your ceftriaxone or cefotaxime. and there is no need to add vancomycin as primary agent, as ceftriaxone resistant pneumococcus is not common in India. And again, listeria is also rare in India, so ampicillin is not indicated. So again, depending upon the patient scenario, if there is an elderly patient, you can still consider adding, but it is not indicated. So next, I want to address a newer BLBLI, ceftazidime-avibactam, because it is becoming more prudent to use these combinations now. So I wanted to address this. So so before I go to the ceftazidime-avibactam, so we need to understand why this came into market. Why are the newer BLBLI use increasing now? So what are these carbapenemonases? These are the enzymes which hydrolyze carbapenem, broad spectrum penicillin, all your cephalosporins and your cefamycin. So carbapenemonases can be of mainly three types. That is your KPCs, MBLs and OXA48. So your KPC and OXA48 belong to Ambler class A and B, and these are serine carbapenemonases. Another category is your MBLs, that is metallo-beta-lactamases, which belong to Ambler molecular class B. And so if you look at the substrates, so KPC has all beta-lactams as a substrate, MBL all beta-lactams except for your aztreonam, and OXA48 all penicillins and your carbapenem. So when you look at this, so avibactam will inhibit your KPC and your OXA48, but not your MBL. So in presence of this avibactam gets hydrolyzed by your MBL. So that is why they have used this combination. So when you look at the rationale behind this combination of ceftazidime-avibactam, so you can see ceftazidime has can act on class D, but whereas avibactam protects the ceftazidime by the inactivation by the beta-lactamases, and as such, this avibactam, it's a non beta-lactamase inhibitor. It has limited antimicrobial properties. However, by pairing it with ceftazidime, it will restore its activity and effectively turning black the clock prior to the emergence of this resistance. So when this table, if you look at, so whatever the action ceftazidime is not having, whereas avibactam is having those action, and hence this combination is having a rationale behind it, and the ratio of this combination is 1:4. And you can see which class it is not acting, class B. As I have mentioned before, class B is your metallo-beta-lactamases. So this combination, just like any other beta-lactamase inhibitor combination, it has time dependent activity, and hence the plasma target that is more concentration above the MIC for more than 50% duration. It should be above the MIC, and hence it is recommended that you give extended duration of infusion for over 2 hours. So when you look at the FDA approved indication, it has been approved for complicated intra-abdominal infection in combination with metronidazole. Why are you adding metronidazole? I will be, let's talk about it in the next slide. This is according to the RECLAIM trial, complicated urinary tract infection as per the recapture trial, and complicated ventilated and hospital associated pneumonia as per REPROOF trial. So what are these this combination active against? So this can be effectively used in your ESBL, AMC, OXA48, and your KPCs and your MDS pseudomonas. So basically this combination will act on your Enterobacteriaceae like E. coli, Klebsiella, and in that it will act on ESBL, AMC, and your carbapenemonases like OXA48 and KPC. And as I have mentioned before, it will not have any action on your MBS. And this combination is intrinsically resistant to Acinetobacter and other non-fermenters like the Stenotrophomonas, Maltophilia. And this combination, this is one of the BLBLI which does not have anaerobic cover, and hence you'll have to, if you have to give this drug in a patient who is having abdominal infection where anaerobic organism is also could be a positive agent, you will have to add an anaerobic cover like with metronidazole, and it does not have adequate gram-positive cover as well. So what are these ESBL, AMC, etc. I have covered in my webinar. So you can just have a look if you are not sure about those. So what is the role of BLBLI in Indian settings? So if you look at the various BLBLI which is available, so excuse me. So most of these BLBLIs are not currently available in India. Which are available is ceftazidime-avibactam and in few places ceftazidime-avibactam. So you can see most of these newer combinations like meropenem-vaborbactam, imipenem-relibactam, and your aztreonam-avibactam. These are not currently available, and aztreonam-avibactam is currently in the FDA phase 3 of the trial. And most of these will not have any action on your NDM, which is nothing but metallo-beta-lactamases. And other agents, cefiderocol, plazomicin, and avacycline is currently not available in India. So what is the role of BLBLI in E. coli? So again, whenever you are looking at a treatment option, you will have to understand the local epidemiology of the resistance pattern. So when you look at in Indian settings, your most common carbapenem is your NDM, and that is your metallo-beta-lactamases. So you will have to think about that whenever you are thinking of whenever you encounter carbapenemesis, and you should always ask your lab to perform detection for your MBL at least. So now when you look at E. coli, whenever you are giving treatment of MBL, you can't give ceftazidime-avibactam as I have mentioned before. But aztreonam, as I have shown before, aztreonam has action on your, it is not hydrolyzed by your MBL. So you can add aztreonam to the ceftazidime-avibactam for use in MBS. But again, one important thing to note here is in E. coli, there is something called PB3 inserts, which makes ceftazidime-avibactam-aztreonam also less effective. So let's learn about aztreonam. Aztreonam is nothing but a monobactam which is unaffected by your MBS, and thus these are the only beta-lactam which are effective in organisms which are MBL producers. And this has a unique PBP, that is penicillin binding protein inhibition profile, and has potent and specific affinity towards PBP3, and this is which is involved in cell septation. E. coli in India, instead of having there is some insertion sequence which has happened in the PBP3, which will make that drug will no longer be able to go and bind to it. So it was making some obstruction because of this insertion. So the aztreonam is no longer able to bind to it. So it is preferred that in E. coli you'll be going for colistin base. Again, you can try with ceftazidime-avibactam-aztreonam. If there is no response, you can move to colistin. Next, Klebsiella pneumoniae. For NDM, you can give easily the combination of ceftazidime-avibactam and aztreonam. In case of non-NDM, only ceftazidime-avibactam can be given. Pseudomonas, NDM, it is recommended you give polymyxin or colistin-based therapy. In non-NDM, ceftazidime-avibactam or ceftalozone-tazobactam can be used. Why? As I mentioned, aztreonam does not have good action on your Pseudomonas. That is why it is not preferred in Pseudomonas. Acinetobacter, as I mentioned before, aztreonam is intrinsically resistant to aztreonam. Acinetobacter is intrinsically resistant to aztreonam as well. Your ceftazidime-avibactam has no action on Acinetobacter. So this combination is of no use when you look in Acinetobacter. So you'll have to give a polymyxin-based regimen. So what polymyxin? Again, the IDSA recommends a triple drug combination therapy. So which I have covered in the IDSA AMR guidelines. So that again I'll be attaching, I'll be linking it above. So next, so you have decided to give ceftazidime-avibactam and aztreonam. So how will you give this drug? So is it that you will just give ceftazidime-avibactam over 2 hours and then you'll give aztreonam? So that is a very common wrong practice. So this is what I wanted to highlight here. Whenever you're giving ceftazidime-avibactam with aztreonam, it should be administered simultaneously to have an action. So suppose, as I mentioned, ceftazidime-avibactam alone does not have any action on MBL. So you give ceftazidime-avibactam in a patient who is having MBL, this drug will get hydrolyzed. Then you are giving aztreonam. Only aztreonam will not have any action on other type of beta-lactamases. So effectively, you are not giving any drug. It is leading to therapeutic failure. So you have to administer simultaneously and never separately, and over minimum of 2 hours it should be administered. So to avoid the therapeutic failure, so you can take the same ceftazidime-avibactam lyophilized the powder and your aztreonam powder, both of which it can be included in the same NS bottle, and then that could be used for administration. So and this combination can be used even in MBL, as well as if aztreonam is given to be resistant as per the report as well. And it has good penetration into the tissue, lung, and blood, but limited penetration into CNS. So in CNS infections, you can preferably avoid this combination. And as I mentioned, this combination does not have anaerobic cover. So you will have to add an anaerobic agent to cover the anaerobes like metronidazole for in cases of intra-abdominal infection. And whenever in cases of severe or serious infection, you can give a continuous infusion over 24 hours, and these are BLBL like combinations, so you will have to adjust the dose according to the renal clearance. So next important topic I wanted to address is the surgical prophylaxis. So this is one area where the antibiotics are very much like I can say misused. So why do you need this surgical prophylaxis? So why is this? So this is the antibiotic which you are administering before surgery to help decrease the incidence of post-operative infection. So when do you administer it? The optimal time for administration is at least within 120 minutes. So actually WHO initially had mentioned 60 minutes. So and depending upon the half-life of the antibiotic, so within 60 minutes or within 120 minutes, 120 minutes is the final cutoff which you can administer the antibiotic. And what is the duration of prophylaxis? A single dose of antibiotic, or you can continue it for less than 24 hours. So if depending upon the T half of the drug, so if your operation duration is extended, you can add, but the duration of prophylaxis should be discontinued. This prophylaxis should be discontinued within 24 hours of initiation, and there is no necessity to prolong this surgical antimicrobial prophylaxis after the completion of the operation, except in cases of cardiothoracic surgery where up to 48 hours is permissible. So what antibiotic should I give? So your antibiotic cover should include most common organism associated with surgical site infections, and depending upon your local antibiotic resistance pattern, like Staphylococcus aureus, Staph epidermidis, aerobic streptococci, anaerobic cocci. Basically, these are the more common commensals over the skin which you will be covering. And what antibiotic you are giving depends upon the route of administration, dosing, and you should always consider the patient's allergy. So so one more important situation is the patient underwent some like abdominal surgery, and there is a drain in place. So if there is a drain in place, is it necessary that you prolong the antibiotic prophylaxis? So it should not, this is not a practice. Preoperative antibiotic prophylaxis should not be continued in presence of a wound drain for the purpose of preventing SSI. So these guidelines, these are the WHO guidelines which have taken. So again, what antibiotic depending upon the type of surgery. So this tables I will leave it for you to see. So most often the most common agent which is used is your first generation cephalosporin, like your cefazolin. And one more thing is, so your hospital has SSTI, SSI infections more commonly with your ESBL or it could be MC produces. So what should I give as an empirical surgical prophylaxis? Should I just give first line, or should I give a carbapenem to cover the surgical site infection? So this part the WHO has clearly decided not to comment, and again they do not also recommend covering a higher with a higher agent. So basically you are not you are covering the usual pathogen, which is usual commensals over the skin, and not the pathogenic organism. And also one more important consideration you should give is the duration of stay in the hospital before the patient was taken up for surgery. So if you have just admitted the patient for the surgery, say, and there is no enough duration for the colonization with the hospital flora, so it doesn't make sense that you will be covering the more resistant organism. So in cases of clean surgery, again, there is no requirement of surgical antibiotic prophylaxis. Clean contaminated cefazolin, so cardiac surgery, thoracic surgery, breast surgery, you can look at. So second line agent you will be taking into consideration only if and only if the patient is having proven a severe allergy to penicillin and your cephalosporin. So these are the second line agents only if it is allergic and it is not the combination you are taking. So there is nowhere they have mentioned that you have to cover cefazolin with your vancomycin. So hernia surgery, again, most of the places it is the same cefazolin which is considered to be used. This is the recommendations by the national. These are the national guidelines. Again, here most of the places in breast surgery, cefazolin is recommended. Gastroduodenal and biliary cephalosporin sulbactam, and for maximum duration of 24 hours, ERCP, piptas, cardiothoracic cefuroxime, colonic surgery, cephalosporin sulbactam, abdominal surgery, cefazolin, head and neck cefazolin, neurosurgery, cefazolin or cefuroxime, orthopedic cefuroxime or cefazolin. So, and all these they recommend only up to 24 hours. There is no recommendation that you need to continue the antimicrobial prophylaxis beyond that day. So yeah, AMR, again, this is a global health priority now, and there is so much increase in resistance every second. So you have to handle antimicrobials with care, which includes not only your antibiotics, antivirals, antifungals, as well as antipyretics. So spread awareness and stop resistance. So that's it. Thank you.